All right, let's give a hand for Amanda Leggett.
All right, good morning, everyone. I hear Beyonce's in Detroit today. I'm not Beyonce, but I'm giving you a little bit of that Jumbotron experience this morning. I'm really sorry not to be there with you, but you can probably hear through my voice that you wouldn't want me in person with you. And I do apologize in advance if I cough, as I'm still recovering. So thank you for your patience with me this morning and dealing with me on the big screen. So I'm really thrilled to be able to share with you about one of my current research projects on what I call caregiving style. And I'll explain to you what I mean by that in just a minute. And in this project, we're actually developing a measure that a caregiver themselves could use, a clinician could use, a community service agency could use, a researcher might be able to use to help identify what someone's caregiving style approach is, so that we can think about how we can use that to better tailor and target and think in a more individualized way how we can go about approaching caregivers to achieve more personalized results. And so the goal is we see that these caregiving styles, and again, I'll share with you a bit about this in just a minute, we see that they are associated with outcomes for caregivers. And so if we can think of caregivers, and by caregivers, I'm talking here about family members and friends who are providing care for someone with a dementia. If we can look at them in a more individualized way, as opposed to this kind of one size fits all group, which is how a lot of the literature tends to look at them, we can really understand a little bit more how they are as individuals and how they're managing day to day the challenges that they're confronting, how they're thinking about them, what they're actually doing behaviorally to manage care. And we can identify whether particular approaches or styles of care are related to more risky outcomes for both caregivers and individuals with dementia. Then the long-term goal of this work is to be able to take a more personalized medicine approach and to really be able to target caregivers based on how they're actually confronting the challenges that they're facing. And again, not just as this one size fits all group. So this work is actually stemming from a longer study that I did over the past 5 years. It was a career development award from the National Institute on Aging, where we took a mixed methods approach and we did in-depth interviews with caregivers, exploring exactly how are they navigating caregiving challenges in their daily lives. So we asked them to identify a challenge that they'd had recently in their caregiving, and they really kind of walked us through the process of what were they thinking about, how were they responding, what did they actually do? So kind of what did this situation look like and how are they handling it, navigating it, both in the ways that they're thinking and in the ways that they're actually behaving or things they're actually doing. And through this work, we were able to identify really 5 common profiles or 5 distinct caregiving styles that reflected kind of similar approaches that different groups of caregivers would take to managing or navigating these caregiving challenges in their daily lives. So before I get into what we're doing in terms of developing this measure in the current study, I thought it might help for you to understand a little bit more about what these styles are and kind of what we're trying to identify here. So the first style we call the externalizer. And at the top of each slide, you'll see I provide a characteristic quote that really kind of represents this group well. And so one of our caregivers that was an externalizer said, I'll say, if you think you're punishing me, you're only punishing yourself. And what you can really see in this quote is that this group of caregivers really had a more superficial understanding of dementia. So they would say in words they knew that their relative or their friend, family member had a dementia, but they really viewed the symptoms of dementia as volitional or as intentional, as trying to punish the caregiver, for example. They didn't view them as actual symptoms of a progressive disease. And then similar to that, their approach to care was pretty rigid, pretty inflexible. So they were not really good at adapting when different challenges were confronting them. They tended to have kind of one approach, and even if it wasn't working well for them, they were unable to change with that approach. In their interviews, they really talked a lot about how stressful caregiving was to them, the caregiver, and they focused less on how stressful the challenge or the context of the situation they were describing may be to the person living with dementia who was going through this challenge. Then behaviorally, we see externalizers responding with feelings of helplessness, frustration. For example, they might blame the individual with dementia for what is going wrong in the situation, or respond with anger, even yelling in some instances. And then one interesting thing we saw a lot with this group was trying to really reel the individual with dementia kind of back into the lived experience of the caregiver. So, for example, one husband saying to his wife, like, she's lying to me, that didn't happen. Your mother died 20 years ago. So trying to bring the individual with dementia back into the current reality, as opposed to kind of being able to go along with that individual in this new reality in which they're experiencing things with dementia. Our second group we call the individualist, and their characteristic quote is, "You just live through it, you just do it." And in fact, we were calling this group the Just Do It, kind of like the Nike slogan for a while, because that particular phrase came up again and again in the interviews with these individuals. You just do it. So these are a very linear group. We tend to think of them kind of like a lone wolf, where they take all of caregiving on their own shoulders, and we're not really good at delegating tasks or getting other individuals involved. They tended to take a more removed emotional approach when they were talking about the challenges. So they would just describe what they did to handle it in a very direct way, but not really bringing emotions into the picture of how they were describing these things. Behaviorally, they were trying to prevent a particular challenging behavior, for example, that the individual was showing. They were trying to prevent it from happening again in the future, and yet they weren't necessarily able to adaptively think about how they might respond to it in the here and now, or what are different approaches they might take in managing the challenges. And yet, despite this, they were actually doing pretty well without hitting many roadblocks in their caregiving. So tending to put things on their own shoulders and kind of navigate it themselves was actually working pretty well for this group. Our next group we call the learner, and their characteristic quote is, "So as you go along, you stumble on a few things, but stumble it is." So this is a group that was trying so hard to address these caregiving challenges that they were navigating. But what was happening was they were often getting stuck or kind of hitting a wall as they were trialing and erroring different approaches. So we saw them, trying a variety of different things, but what they kept consistently telling us was that nothing that they were trying behaviorally was really working for them. And they were really on kind of this range of some more adaptive caregiving practices and then some more maladaptive practices. But regardless of what they were trying, it wasn't working for them. So the challenge was continuing. They weren't able to address it in their caregiving, but they realized that it wasn't working for them. They needed a new approach. In contrast, our externalizer and our individualists didn't really have that same self-awareness that maybe the approach they were using wasn't the best or most adaptive approach. This group recognizes that and is looking for help and just not finding it. And they're showing a lot of emotional range in their interviews. So feelings of guilt, feelings of empathy for the individual with dementia, feelings of helplessness. So we saw a lot of emotions coming up in this group. This group has us really excited, honestly, because we feel like this is a group that would really thrive in something like a behavioral intervention that a lot of researchers work on developing to help caregivers address, for example, behavioral and psychological symptoms in dementia. Whereas our externalizer and individualists, they may need some different sorts of supports before they'd be ready to dive into some sort of behavioral intervention. Next, we have our adapter. And this quote is, "Always expect the unexpected." And in contrast with our other groups, the adapters had like a huge cornucopia of different strategies that they would use to manage caregiving challenges. So rather than having to trial and error, they kind of already had amassed this collection of different strategies they would use to navigate their caregiving challenges. And in contrast with the learner, these strategies were working for them. We also saw them more in kind of emotional homeostasis as opposed to the learner. So they weren't expressing a lot of emotions in their interviews. They were talking more about this array of caregiving strategies that they were able to utilize well in terms of their caregiving. And they also talked about how this was really something they acquired over the course of their caregiving. They were able to learn from prior mistakes that they had made. And in fact, this group had been providing care on average for about 7 years. And so one of our interests is how can we get an externalizer, an individualist who maybe doesn't have these adaptive caregiving strategies to become a little bit more like an adapter, but and not take 7 years to get there. And of interest, behaviorally, they were also using some were maladaptive strategies and some were adaptive strategies, but regardless of what they were using, it was helping them to address the challenge. And then finally, we have our nurture. And this is a group that focuses most on making the most of what is present rather than what is lost. So this is a group that's approaching caregiving with a lot of positive affect, self-efficacy, and mastery. They probably contrast the most with our externalizer group. So whereas the externalizers were really talking to us about how stressful this caregiving situation was for them, the caregiver, our nurturers interviews really focus more on how stressful the situation or context must be on that care recipient or that individual with dementia. But again, they were able to approach their care with just natural adaptability and a lot of positive affect. So they viewed the situation as something they could handle and they could handle well. Behaviorally, they use a lot of comfort. So they're comforting the individual with dementia. They also do things as a team. So they would describe how when they were faced with a challenge, they would work together with the individual with dementia to resolve that challenge. One great example I have of this is a gentleman who was struggling to get his wife to brush her teeth in the evening. So he turned it into a little game that they would do together. He would turn some music on and a timer. And while the music was on and the timer, they both brushed their teeth. And then when the timer stopped, they could stop. So it was something he turned into a game that they did together, as opposed to something he was just telling his wife to do independently. And they were really able to kind of dive into this altered reality that often can come with a dementia. So for example, if an individual with dementia was having a hallucination, the caregiver might actually actively interact with that hallucination, tell, whatever the individual with dementia was seeing to get out of the room, as opposed to saying, there's nothing there. What are you talking about? And questioning that individual. And so, as I said, one of the reasons we're very interested in this is that we actually see significant differences between these style profiles on some important outcomes related to caregiving. So in red, our first group, the externalizer, we actually found that this group was made up entirely of Caucasian Americans. In this study, we collected saliva samples to look at some biomarkers. One of those was cortisol, which is a commonly measured stress hormone. And we found that this particular style had significantly elevated cortisol output, reflecting a more negative physiological stress profile. So the stress of care was actually getting under the skin for these individuals. Next, we have our individualists, and you can see 1 in 3 of them had difficulty in paying for living expenses. So their direct or linear kind of just do it themselves approach may be what they needed to do because they had other very serious, living concerns on their plate. And this was a group that was expressing the most stress over functional tasks of caregiving, those activities of daily living like dressing and bathing and cooking. Our learners had a larger proportion of females in this group. 40% of our learners were taking an antidepressant or anti-anxiety medication, which may reflect some of that emotional experience that we were seeing in this group. As I said, our adapters have been providing care for about 7 years on average. We also saw the largest proportion of non-white caregivers actually fell into this more adaptive caregiving style. And then finally, our nurture style tended to show the most positive outcomes. So they reported the least amount of stress related to behavioral and psychological symptoms and also functional activities of daily living. They also told us that the individuals with dementia in their care had the highest quality of life. So we tended to see more positive caregiving outcomes for this group. So where are we now in this current study? So currently I'm part of a 2-year award from the Alzheimer's Association where we're developing a measure that can actually help someone identify what caregiving style they are currently. And as I said, we believe this is important because we can't always run sophisticated statistical models or do in-depth interviews to figure this out. Having a brief about 20-item measure that can quickly kind of identify for us what style someone is may help us better point them towards services that would be more useful or get them in the right intervention, or treat them, according to their profile, again, as opposed to this one-size-fits-all group. And so this is my team. I'm fortunate to have an incredible group at universities around the country involved in this work. And so we're developing currently this measure. It's kind of been a long process of 2 years. Where we started was from the original work that I just described to you. We were able to develop several hundred items that get at different aspects that reflect these domains that make up these caregiving style profiles. And so we developed as many as we could. Some of them came exactly from caregivers' words that they used in their interviews, and others we created based on what we were seeing, kind of themes that were emerging from those interviews. So we created these hundreds of items. They were reviewed by experts in the field. And we had 7 caregivers actually review all the items and provide us in-depth feedback. So they told us, if they didn't like the wording of an item, if they felt it was too negative, they let us know. If they felt there was a concept that was missing from what we were trying to capture. So we got their feedback, and all through this process, we're iteratively refining these items. We also went through a review process to make sure that the items were an 8th grade reading level, so that they would be accessible to the broad population in the United States. And they also went through a review by a company that reviews specifically for the ability to translate into other languages. We want to make sure that once we develop our measure, it can, for example, be translated into Spanish or other languages, so it can be used more broadly. So that is where we have been so far. And then what we're currently doing is we are testing. We iteratively refined our several hundred items down to 100 items that we are testing currently. We're recruiting 200 caregivers to test out these items. We want to better understand how they work, which particular items best distinguish between people so that we can create the best measure that we can. And then we're also collecting some other scales, some other measures in this survey so that we can compare our items that we've developed to other existing measures related to caregiving and caregiver well-being. So as I said, currently we're in the process of recruiting these 200 caregivers to take this survey for us to help us essentially boil these 100 items down to approximately 20 items that are going to capture these caregiving styles and help us to classify an individual caregiver into their current style profile. Currently, we have about 125 caregivers enrolled in our study. So we're hoping you might be able to help us get that last 75 to get to our total 200 that we need to run these analyses. So who can participate and what does participation look like? So I believe my research assistant, Sophia, is in the room and she can answer questions in person for you, as she's the one you would actually be speaking to get involved in this study. But any adult, so anyone 18 years or older who is a family member or friend of an individual with an age-related dementia, a doctor's diagnosis of that age-related dementia, someone who's currently providing care. So unfortunately, we can't take former caregivers. We are looking for current caregivers who are providing any type of care, whether it be emotional, physical, like activities of daily living, even financial care for that individual with dementia. And we're looking for this individual to have a pre-existing relationship. So, for example, not being a paid caregiver who's been hired into this role, but someone who already had a relationship with this individual and is unpaid for their caregiving role. And then as far as the individual with dementia, we are looking for them to be community dwelling and with a life expectancy of 6 months or greater, essentially not to be on hospice, because we are looking for the caregiver to be actively engaged in the caregiving role and not in a terminal phase of caregiving. What's involved? It's really pretty easy as far as research goes. I like to think so you would just have a quick screening phone call with Sophia, again, who's in the room, just to make sure that you qualify. And then if you do, you're sent an individual link that is specific to you to take one online survey. It's been taking our participants about an hour. You don't have to do it in one sitting. For example, you could do a little bit of it, come back to your computer later and finish it. So it's pretty flexible in that regards. And then on the next day, it's optional. But if you would like, on the next day, you could be sent a shorter online survey that just has those style items that we developed to do a quick retest on those items. So participants who complete the hour-long survey get a $30 gift card that you can choose. You can choose from literally thousands of options for where that gift card can be. And then if you complete the next day shorter survey, you can get an additional $10 gift card. So what's next? As soon as we reach our 200 participants, we'll be running our analyses to develop this measure of hopefully, again, about 20 items that we really hope can be used by centers like the Michigan Alzheimer's Disease Center, or community service agencies, clinicians, caregivers themselves, just to learn more about how you yourself are navigating care and how understanding that might help you, seek out more specialized services and things like this. And so our goal is to be able to look at caregivers in the unique ways that they're providing care, acknowledging both their strengths and maybe areas or room for growth that they may have in their caregiving approach, so that we can best meet your needs and help you grow and be the best caregiver you can be, so that you'll have hopefully more positive outcomes as a caregiver and be able to provide optimal care for the individual with dementia. And so again, I believe Sophia is in the room and she can answer questions in person, but I've listed both of our emails here and we're happy to answer any of your questions. So I would like to acknowledge my funding from the Alzheimer's Association. Also, the work that supported this research was from the National Institute on Aging, and I am also supported by the Michigan Alzheimer's Disease Center. I have a wonderful team of collaborators who have been involved in this work all across the country. And I think even more importantly, I have a fabulous research team. I've listed everyone here on the right that's been a part of this study, and more than half of these individuals are undergraduate students at the time they were working on this research. And so that's also a great passion of mine, is getting students involved and passionate about dementia and dementia care. So hopefully the next generation of great minds will also be caring about this important issue. So thank you so much. With that, I will end, and I'm happy to answer questions if I can. Stephanie, you just let me know.
Can you hear us?
I can hear you.
You can hear me? Okay, so that means the upper microphones might be working. So we do have time for a couple questions. Does anybody have any questions for Amanda? Would you like to?
Yeah, Amanda, thank you. Isn't it normal for any individual to begin at the externalizer?
Yeah, that's a really interesting question. So what I heard was, isn't it normal for any individual to begin at an externalizer stage? So what's interesting is we actually saw that the externalizers reported that the individuals with dementia for whom they were providing care had the most severe behavioral and psychological symptoms. So while they were showing greater stress for navigating these symptoms, they're also dealing with very complex individuals with a variety of symptoms that they are trying to navigate as a caregiver. So we actually saw it a little bit more common at a moderate stage of disease, where we see more of these behavioral and psychological symptoms. But I do agree with you. I do think we see individuals come in and out of these different style profiles at different times. Our study was actually longitudinal, meaning we followed these caregivers over time, and we did see people change over time. So I do agree with you. I think it is quite natural for individuals to, at first, struggle to come to terms with this diagnosis and view these symptoms, in a way that can be filled with frustration and anger. And these are natural emotions. So yes, I do think it's not uncommon for people to be in that particular style at some point in their caregiving. But we actually saw again, that these were individuals who were providing care for individuals with severe behavioral and psychological symptoms on average. So generally more at the moderate stages of disease is what we saw in our study. But I do think it's common for people to be there at some point. And as they learn, as they grow, as they seek services and get help in their caregiving, it's common for people to transition to different caregiving styles. Our hope is that in measuring these and helping to provide a more tailored approach, we can help people, develop more adaptive approaches more quickly rather than the 7 elapsed years, for example, of someone who's in that adapter style.
Right. Thank you very much. And like Amanda said, Sophie is here. If anybody has any questions later on. Thank you so much for making yourself available, even though you're slightly under the weather still.
Yeah. Thanks for bearing with me in this format.
Yeah.
I greatly appreciate it.
You're welcome. All right, we'll see you later.
Okay, thank you. Bye.
All right, thank you so much for your patience, everybody. Our next speaker is Dr. Courtney Polenick. She is an assistant professor in the Department of Psychiatry and faculty associate in the Aging and Biopsychosocial Interventions program of the Survey Research Center at the U of M Institute for Social Research. Her research focuses on later life family relationships and caregiving in the context of complex care needs, including dementia and multimorbidity. Give a hand for Polenick.
Thank you so much, Cynthia. And thanks everyone so much for being here today. I'm excited to have an opportunity to talk with you about some of our current research and some of our exciting upcoming studies. Can everyone hear me okay before we get started? Good, okay, perfect. All right, so I'll tell you a little bit about our research today on daily experiences and well-being in people living with dementia and their care partners. And by care partners, we mean basically family members, friends, neighbors who support somebody living with dementia. Not advancing. It seems like it's working manually.
Seems like it's working.
So it's this one. That one. Got it. Thank you. Okay, apologies about that, little technical difficulties. So we'll start today talking a little bit about our overall research program and what the goals are in our research. I'll tell you about a current study that we're recruiting called the Couples Wellbeing and Everyday Life Study. And I'll also share a little bit about some upcoming research studies that we're excited to share and will be opening up to recruitment in the coming months. And then finally, a summary and just some future directions that we'd like to go with our research. So the overall goal of our research program is to understand experiences that are happening in everyday life that will help us find ways ultimately to improve the well-being of people living with dementia and their care partners. And our studies all do assessments over a period of days and typically multiple times a day to really get a sense of what's happening in your life as you're living it. A lot of studies focus on sort of asking about the past week or the past month and things that you did and how you felt. And while that's very valuable, we also think it's really important to know what's actually happening as you're in the moment, as you're living your life. And we feel that understanding what's happening with caregivers and people living with dementia in terms of their activities and how they're feeling throughout the day is really, really important to know in terms of finding ways to help support their well-being. And we've also found in our preliminary research that people both differ from other people in terms of how they're experiencing their days in terms of their mood and how they're feeling about, their care role, that sort of thing. It changes both within the individual across time, across days, but also between people. So people tend to vary a lot in how they're experiencing their days. So the first study is the Couples Wellbeing and Everyday Life Study, and this is supported by the National Institute on Aging. And what we're really interested in this study is understanding how both members of a couple, so these are married partners or cohabiting partners, influence one another's well-being on a daily level. So we know that previous research shows us that spouses or partners really do affect one another's well-being, which makes sense because they tend to share daily routines. They kind of, share stressors sometimes. So they really tend to be influencing one another quite a bit. But we really don't know much yet about how these influences are happening on a day-to-day level among people living with dementia and their spouses or partners. So what we really want to learn about in this study is how can we learn about this daily stress and how it's impacting well-being in both people living with dementia and their spouses or partners. And so we're planning to recruit 40 people living with dementia, early symptoms of dementia, either with a diagnosis or without a diagnosis, and their spouses or cohabiting partners. And we're really close to getting to that goal. We need just 5 more couples to reach the goal. So we'd love to talk with any of you if you might be interested or know someone who may be interested in participating. So basically, what is involved with this study? We have people living with dementia and their spouses are both individually completing an initial phone interview that takes about an hour. We ask questions just about their overall situation, their mood, that sort of thing. Next, we have both people living with dementia and their spouses complete 7 days of short phone interviews. So this sounds like a lot, but people have found it quite manageable. We do morning interviews that take about 3 to 5 minutes, where we just ask about your sleep and your overall mood, kind of how you're feeling. Then we have an evening interview where we ask more about daily activities, types of stress you might have encountered, but also positive things that might have happened in your day. And that tends to take about 15 minutes. And we also schedule these based on participant schedules. So if you prefer to have your morning interview at 7, we can do that. Or if you prefer to have it at 11, we're very flexible in terms of time for both the morning and evening interviews. And then during the 7 days of phone interviews, we also have people living with dementia and their spouses collect 4 days of saliva samples. So this is done at waking, 30 minutes after waking, before lunch, and before bed. And the reason for this is because we want to assess stress hormones, so specifically cortisol and alpha amylase, and see how those hormones are changing throughout the day in relation to what people are actually experiencing in their day. So we can really find out about sort of how people are responding physiologically to stress as well as emotionally. So the collection period takes about 2 minutes, so it's really not too time consuming. We do have, let's see, okay, good, glad that showed up. We do have just a photo to show you. So we have color coding within days. So the first day is coded as red, and we have the times for the samples on labels. We also have the tops of the caps for the tubes color coded by time, just to kind of help people keep track of the samples. And everybody so far has said that it's been fairly straightforward. We're always available to help if there are questions. So for this study, people living with dementia and their spouses will receive a combined total of up to $200 for their participation. And if you're interested in participating, you can contact us at the number listed or seawellstudy@umich.edu. My wonderful study coordinator, Charity, is here in the back of the room. So she's also very happy to talk with you if you'd like to hear a little bit more about the study, or if you'd like us to call and speak with you more about it as well. So moving to the next one, this is a study that was recently funded by the Alzheimer's Association, and it's called the Resilience and Sleep and Everyday Life Care Partner Study. And this study is focused on understanding how everyday experiences are impacting sleep in Black caregivers and also in the people living with dementia that they support. So we know from previous research that Black older adults are about twice as likely to live with dementia. However, we really don't know much about the daily experiences that are impacting well-being in Black care partners and their people living with dementia. And so what we really want to learn about in this study is how can we identify positive and negative experiences in everyday life that are influencing sleep among Black care partners and people living with dementia. And in this study, we're specifically interested in experiences among Black care partners. And so we'll recruit a total of 50 Black care partners who live with and support a person living with dementia in Michigan. First, care partners and people living with dementia will both complete an initial phone interview. And this will be about an hour for care partners. And for people living with dementia, this will take about 15 to 20 minutes, so a little bit more of a focused interview. And next, we will have care partners complete 21 days of taking very brief smartphone surveys. So this will involve getting surveys by text message, either on your own smartphone, or if you don't have a smartphone, we can provide one for the study. People will complete a very, very brief morning survey about their sleep, an afternoon survey about some, stressors that they might have experienced so far, their mood, again, very brief, about 5 minutes. And then finally, an evening survey will ask more in-depth questions about the day, things that have happened, and how care partners have coped with kind of things that have happened throughout their day. And during the same 21 days, we will also be asking care partners and people living with dementia to wear a wrist activity monitor for these days. And this looks, as you can see, very similar to like a Fitbit. It's very lightweight, so kind of like a watch that people wear. And they'll wear it continuously because we really want to be able to get a sense of their activity throughout the day, but then also understand their sleep quality as well. So this device will track both activity and sleep. And then finally, care partners will complete a brief follow-up phone interview that takes about 20 to 30 minutes. And this is really to help us with developing future studies. So we'd love to hear thoughts on how well the surveys captured what they actually went through in their daily life. So we really want to make sure that we're asking the best questions. And also we're interested in any suggestions for future studies using smartphone surveys and wrist activity monitors and what we can do better in the future. Care partners and people living with dementia will receive up to a combined total of 192, and we expect to start the study sometime this fall. And next, I'll talk a little bit about another study that was recently funded by the National Institute on Aging, and this is focused on daily experiences in couples living with early stage dementia and the implications of those experiences for daily sleep and long-term well-being and cognitive function. So we know from previous research that care partners and people living with dementia often have sleep problems. And over time, these sleep problems can lead to health problems, as well as decreases in cognitive function. But we really don't know much about the daily experiences among care partners and people living with dementia that are impacting sleep. So we really want to know in this study how daily stress and positive experiences, both related to the care situation, but also just more broad experiences, are influencing sleep along with long-term well-being and cognitive function over a 2-year period. So this is a bit of a longer-term study. So for this study, we'll recruit a total of 150 married or cohabiting couples living in Michigan. One partner will live with early symptoms of dementia, either a diagnosis of dementia or without a diagnosis. And also we want both partners to be age 60 or older because these individuals are at higher risk of cognitive impairment. So in this study, first, we'll ask people living with dementia and their spouses to complete an initial phone interview, and this will take about an hour. And then we'll also have them both complete a series of cognitive tests, and typically we find that these take a total of about 1.5 hours to 3 hours. Next, we'll have people living with dementia and their spouses both complete 7 days of short smartphone surveys. This is similar to the previous study, but just fewer days. So this will involve a morning survey, very brief, and then 3 surveys every 3 hours, mostly asking about mood and experiences in the past 3 hours. And we'll finish the day with an evening survey that will take a little bit longer because we want to know with that one more about coping strategies and just overall thoughts for the day. And that typically will be about 15 minutes. And then also we'll be having the people living with dementia and their spouses wear a wrist activity monitor, the same as in the previous study I just talked about, only this will be for a total of 7 days. And this is to get a sense of their activity during the day and then also their sleep patterns. And finally, we'll ask people living with dementia and their spouses to complete follow-up phone interviews and cognitive tests 1 year later, and then again 2 years later. So we really want to get a sense of how these daily experiences and how people are reacting to their daily experiences is actually affecting their well-being and their cognitive functioning 1 year and 2 years in the future. So for this study, people living with dementia and their spouses will receive a combined total of up to $600 over the 2-year period. And we expect to start this study sometime this fall as well. And then the last study that I'll tell you a little bit about is funded by the Michigan Alzheimer's Disease Research Center. And it's focused on daily experiences and well-being in a co-resident adult-child dementia caregiver. So this just means living with a person with dementia, and views of co-residents within that dyad. So perspectives from the care partner, but then also the person living with dementia. So we know that adult children represent about half of care partners who support people living with dementia. And we also know that about 2 in 3 care partners live with parents living with dementia. So this is a pretty good chunk of caregivers in general. And we also know that adult children have unique difficulties and challenges sometimes with balancing caregiving, along with things like childcare, their marital role, work roles. So they often have really a lot of things going on at that time. But we really don't know much about daily experiences that are affecting well-being in care partners who recently started living with their parents. So these would be children who are recently either moving back in with their parent or having their parent move with them, and kind of going through that transition. That can certainly be challenging, but also there can be rewards associated with that change. But we really don't know much yet about those specific challenges and rewards of living together. So in this study, we're interested in examining how daily stress and positive experiences affect well-being in adult-child care partners. And then we're also interested in learning more about the challenges and rewards of living together experienced by care partners and their parents who recently started living together. So we'll recruit a total of 30 adult-child care partners and people living with dementia who started living together within the past year. So it's a pretty recent transition for them. And first, we'll have care partners and people living with dementia both complete a phone interview. This will be about an hour for care partners, and for people living with dementia, it'll be about 20 to 30 minutes. And this will include open-ended questions about their experiences. So we'll really give people a chance to share their thoughts. Also, we'll be asking care partners to complete 14 days of taking short smartphone surveys. So this will be, again, just brief morning, afternoon, and evening surveys, depending on their own schedules. And again, if people don't have their own smartphones, we will provide one for the study. Finally, we'll have care partners complete a brief follow-up phone interview that takes about 20 or 30 minutes after they're finished with the study. And this will be, again, we're really wanting to know their thoughts on how well the surveys were actually capturing their daily lives and what's happening to them, as well as their suggestions for future studies that use smartphone surveys with adult-child care partners. And care partners and people living with dementia will receive a total of $97, and we expect this study to also start sometime this fall. So in terms of just kind of wrapping things up, we're really hoping that all these projects will help us learn more about how daily life is affecting well-being in people living with dementia and their care partners. And we're interested in this because we feel that the findings will really inform very effective strategies to improve well-being in daily life for people living with dementia and their families. So we thank you very much for your time. Please feel free if you have any questions. I'm happy to answer them today, but also feel free to email myself or Charity, my study coordinator. We have a phone number for her or an email, and you can also certainly feel free to talk with us before you leave today. But thank you so much for your time. I really appreciated the opportunity. Yes.
In the second one.
Yes.
Rather than marking it all, like, early stage or early stage. What do you consider early stage symptoms. Don't have.
Yeah. So generally, that's a great question. Generally, early stage symptoms would be just that they're sort of starting to have some difficulty in their everyday functioning, but it's just a little bit of short-term memory loss, maybe forgetting where you put something or that sort of thing. So just kind of starting to experience some challenges in kind of navigating daily life. Well, that's the truth. Certainly, we all do every day. But this would be, I guess, how I would differentiate it would be something that they're sort of starting to notice is kind of making it harder to do things in daily life.
Nothing profound.
Not necessarily really profound, but just they're starting to notice that they kind of forget things more frequently. That maybe they forget to do how to make a recipe that they used to be able to make every day, like just kind of little things that you're just kind of starting to realize, oh, okay, I'm having a harder time kind of doing what I want to do in my day. So hopefully that makes sense. Great.
Processes.
Yeah, exactly. So just those kinds of things. So we do have an interview with care partners. We kind of talk through these things and help them kind of determine, sort of what makes sense in terms of like, is it early? But that's what we would consider early. Great question. Yes.
What about you guys for you to be able to move forward and learn?
Yeah, so I think I'm not as familiar with research in that area, but I would certainly think that everyone has the potential to learn new things. Oh, that's interesting. Yeah, not that I'm familiar with, but that would be interesting to think about. Like, is it kind of harder to pick up things? But I would say like it's more, my understanding is just more that it's starting to kind of affect like your daily routine, like your ability to kind of do those types of things. But that's a really great thing to think about. Thank you.
I'm just curious, are there any exclusions for these studies, like targeted by cognitive impairment, sleep apnea, medication for?
Yeah. Good question. So there actually are some. So I think for the sleep studies, I know that we're excluding sleep disorders other than insomnia. So there is that. Other than that, there's not a whole lot of exclusion criteria. If they both report symptoms of dementia, we would not be able to enroll the dyad. But other than that, there's not a whole lot of exclusions. Thank you. Was there another question? No. Okay. He kind of answered it. Okay. Great. Any other ones? Okay, wonderful. Thank you so much.
Thank you very much. All right, we're going to be learning about one more study. This study is going to be presented by Dr. Cynthia Burton and Gianna Tunzi. Dr. Burton is an assistant professor in the Department of Psychiatry at the University of Michigan, and Gianna Tunzi is a research technician in the Department of Psychiatry at the University of Michigan. That needs a little clicker to whoever wants to click.
Hi, everybody. My name is Gianna. I'm a research assistant at the research program on cognition and neuromodulation-based interventions. We have Mateo Lopez, clinical research coordinator, here with us as well. Unfortunately, he lost his voice over the weekend, is unable to present with us today, but is here as part of our team. So we are here to talk to you folks today about a new study through the RPCNDI called the Wellness Study, or a comparison of two group wellness interventions for individuals with neurologic conditions and their support persons. This study is funded by the Department of Defense. And to kind of give a little bit more background for this study is a multi-site study, meaning that we are one of 3 different sites out doing this research here. So we are, principal investigator for the Michigan site, focused on those with dementia, is Dr. Benjamin Hampstead. The parent site kind of overseeing the entire study is through the Kessler Foundation in New Jersey, focused on traumatic brain injury research, and their principal investigator is Dr. Denise Kirk.
Don't know how to advance these, so it'll be learning while we go. Okay, so as we know, the population is aging, right? Baby boomers are entering their 70s, which means there are more and more people who are living with dementia, and more people who are providing care and supporting those with dementia. There's a lot of emphasis on both pharmacological or medication-based interventions, as well as non-pharmacological or psychosocial interventions. A lot of these treatments really focus on either patients or their caregivers separately, but not necessarily together. And the existing interventions also very frequently provide support and education, which are critical, and they help families in the moment, but they don't necessarily teach or provide skills for longer term management of these progressive diseases. Oh, I think I turned it off. There we go. Yes. Okay. So we really want to better understand the importance of the relationship between patients and their care partners or their support people as a vital part of the process of care in these disorders. We really want to help encourage including both individuals in future treatments, a more holistic approach to caring for people with dementia to improve the quality of life for everyone involved in these lives. So along those lines, there are 3 specific goals for this study. The first is to examine how effective these group wellness classes are in improving self-confidence, in improving quality of life in individuals living with dementia and their care partners. We also want to better understand whether cognitive functioning, so thinking abilities like memory, learning, processing speed, and other health factors, things like sleep and mood, might affect the relationship between the results that we see in the intervention and perceived caregiver burden in care partners. Finally, we also want to help better understand the neural, behavioral, and any blood biomarkers that might predict improvement living with dementia. All right, Gianna's going to tackle a little bit more study-specific information. Do you want me to advance this or
Yeah, sure. So to kind of give you folks a little bit more information about the wellness study overall. So kind of the main goal of the study, aside from the specific aims that we mentioned, is to compare these 2 different types of group wellness classes that are designed for those with Alzheimer's disease and related dementias, or ADRD, and their support persons. So to kind of go over a little bit more, criteria that makes someone a good fit for the study. And so we're recruiting participants with ADRD who are age 65 or older, with a support person age 18 or older. That individual with ADRD will have a clinical or research diagnosis of Alzheimer's disease and related dementias. They would have no history of another neurological disease such as premorbid epilepsy or multiple sclerosis. No history of psychiatric hospitalization within 3 months of study enrollment. Ability to see and hear well enough to have a conversation in person. No significant history of or current alcohol or drug abuse or dependence. And then there is an optional MRI portion to this study. So those who would be doing the MRI, they would need to be MRI compatible. So to kind of give a little bit information about the study timeline and what types of visits are involved. So the very first visit that participants will come in for would be an in-person screening session. And so this screening session involves completing a few paper and pencil tests to help our team decide if the study would be a good fit for the dyad. And so if the study is a good fit for the dyad, the next visit would be a neuropsych session. And so the neuropsych session is usually completed on the same day as the screening session, but can be on a separate day if that is preferred. And so this session involves completing some paper and pencil tests, examining participants' memory and thinking abilities. And so the support person neuropsych session is brief, lasting only about 30 minutes, while the ADRD participants' neuropsych testing would last about an hour and a half. And so after we have enough eligible dyads after the screening session to start a wave of classes, so this would be about 8 to 12 dyads, that is when our team would go and schedule the baseline sessions. And so the baseline sessions involve the dyad coming in to complete computerized questionnaires. These computerized questionnaires ask about their everyday functioning and mood. And then the ADRD participant will also complete a blood draw during this session as well. Additionally, as I mentioned, there is an optional functional magnetic resonance imaging or fMRI scan, as well as 2 positron emission tomography or PET scans for the ADRD participant as well. And so after completing all of these baseline activities, the dyad would then be randomized into one of 2 group wellness classes with a 50-50 chance of being placed into either class. No matter which class they're in, they would meet with Dr. Burton once a week for 12 weeks for a total of 12 sessions. So Dr. Burton will talk a little bit in a moment about what exactly these classes entail. And so about 1 week after finishing the final class, that 12th week class, the dyad will then come in 1 week later to complete a follow-up session, completing those computerized questionnaires again, and the ADRD participant completing a second blood draw. And so the majority of these study visits take place within this 4-month period. After that immediate follow-up session, there will be no visits for 6 months for the dyad. 6 months after that final group wellness class, they will come in for one final visit though, to again complete those computerized questionnaires and the ADRD participant completing a third blood draw.
Okay, so just for a little bit more detail about the wellness classes and what they might involve. So as we mentioned, these are group-based. They'll include 4 to 6 pairs of individuals. So the person living with dementia, as well as a care partner and a clinician facilitator, so that's me. We'll meet for 2 hours per week for 12 weeks. So it's a pretty lengthy intervention. The goal is really to help people better understand and cope with symptoms of dementia. So for example, topics might include things like healthy activities, physical, emotional, social, cognitive activities, accessing community resources, navigating what's out there, trying to get in communication with providers, as well as communication between the pair and with other family members, addressing changing roles and responsibilities in terms of a newer diagnosis or as things change over time. So just a few sort of examples or a little bit of flavor on what the wellness classes will consist of. That's it for us. For more information, we have Matteo and Gianna's contact information up there. We also have a study-specific email, which is very lengthy. Sorry about that. And we're happy to answer any questions that anybody has if you are interested in more information. Yeah.
I'm just curious, where did the study visit take place? First floor, maybe in
So they'll be in Ann Arbor at the moment. We're really only set up to be conducting the wellness classes at the Ann Arbor location, which is near Domino's Farms, if you're familiar with the area. Some people have asked about virtual, some people have asked about having other locations, so it's something we can certainly explore, especially if there's a lot of feedback and we've reached kind of critical mass in needing to reach people in places other than Ann Arbor. The neuroimaging definitely has to be in Ann Arbor. Yeah, good question.
What level of dementia is beyond accepted?
So there are a couple of screening measures that we'll use. So really severe impairment in comprehension. So really not being able to understand what people are saying to somebody, being able to follow basic directions is really the main exclusion criteria in terms of the severity of dementia symptoms. Because we want people to be able to participate, right? We want people to be able to benefit from hearing others talking and really being able to understand and take in information. So if our screening measures suggest that a person living with dementia might have difficulty with that, we would exclude that. Any other questions? Thank you so much. Thank you.
And just a reminder, if you have not already gotten your validation pass, please see the young lady at the front desk so you can get your validation if you parked in the parking deck behind the building. Other than that, oh, you know what? I can stop this recording.